So I'm very pleased that we're going to be starting off today with a talk by my colleague, Dr. Diana Johnson, consultant clinical geneticist with the EDS service in Sheffield, and she's going to do an overview of vascular EDS. Diana.
So thank you everybody. It feels very strange to be seeing people in person, but it's very nice all the same. As Glenda said, I'm going to do an overview of vascular EDS. So a lot of this information may be familiar to some of you, but I'm not making any apologies for that because it's not known to everyone, so I feel we have to cover all of the basics as well. So the aims of my talk are to give you a definition of vascular EDS, go over the genetics, the diagnostic criteria, how the genetic testing is done, and the symptoms to be aware of. So first of all, what is it? A connective tissue condition characterised by tissue fragility, easy bruising and joint hypermobility. Previously known as type 4, and you'll find with many doctors that you come in contact with, they'll still use this terminology as well. It's very rare, the exact frequency is not known, it's somewhere between 1 in 200 and 1 in 50,000 people. It is a genetic condition which is inherited in an autosomal dominant pattern and is due to pathogenic variants in the COL3A1 gene. Up to 50% of individuals diagnosed with this condition actually have it as a de novo mutation, so that means it's not been inherited from their parents. The COL3A1 gene codes for a protein which is very abundant in connective tissue called type 3 collagen, and this particular collagen accounts for 10 to 30% of the total collagens in the body. So where is this collagen found? Very widespread, present in the vessels, the uterus and the intestinal tract, and this is where patients are particularly prone to problems. So as I said, it's a major component of the body tissues. It forms the scaffolding holding tissues together and is 25% of the total protein in mammals. There are many different types of collagen or proteins, more than 20 different groups, and these are coded for by more than 40 different genes. So the COL3A1 codes the pro-collagen type 3 molecule, as indicated on the far left. That's the initial moiety that's produced. These then form trimers as pro-collagen. They undergo modification into the collagen molecule, and then they form collagen fibers, and fibrils, and then fibers. When someone has a missense mutation in the COL3A1 gene, because of the fact that they're formed into these trimers, someone actually only has 1/8 of the normal functioning collagen. This is in contrast to the people who have null mutations, where their gene is they only produce a protein from one copy of the gene, who have structurally normal collagen but only 50% of the normal amount. So this is a picture trying to show you what genes are in DNA. So at the bottom we've got the sequence of the nucleotides. These group together in threes to code for different amino acids, which are then linked together to form the protein chains. And what do we mean when we say that someone's got a variant in a gene? So in the top picture we have the standard sequence, and you can see in the circled area that we've got the G on the bottom strand. And then if someone has just a point mutation, it means just one base is changed, so the G has changed to an A on the bottom picture. So we quickly go over autosomal dominant inheritance. So we say to people it's a 1 in 2 chance if you have vascular EDS that your children might inherit it. But how do we get to this 1 in 2 figure? So image on the left shows the person who's got vascular EDS, and we have 2 copies of each gene. So the red indicates the variant in the COL3A1 gene, and the white is a normal copy of that gene. And then the picture on the right is their partner. So each of them produce 2 gametes. The person who's affected produces a gamete with a mutation in, and one which doesn't. And then the partner has 2 normal copies of the gene. And so when you conceive a baby, there are 4 possibilities that can occur. You get the mutated copy from one parent and the normal copy from the other. You get the mutated copy again from the affected parent and the other normal copy of the gene from the other parent. And then you get the normal copy from the affected parent and also a normal copy from the unaffected parent, and that can happen in 2 combinations as well. So you can see you've got 2 out of 4, or the equivalent is 1 out of 2 risk of passing it on in any pregnancy. So the criteria for diagnosing vascular EDS were revised in 2017, and these are the current criteria, which show that firstly, if you've got a family history of vascular EDS, you have to have a documented causative variant in COL3A1 for that to be a criteria. The second criteria is that you have had arterial rupture at a young age, meaning under the age of 40. Third criteria is that you've had spontaneous sigmoid colon perforation in the absence of any known bowel disease, including diverticular disease or other bowel pathology. The next criteria is that you've got uterine rupture during the 3rd trimester, and that's in the absence of previous surgery to the abdomen or cesarean section. And people also have significant severe peripartum tears. And then the final major criteria is to have a carotid cavernous sinus fistula formation in the absence of trauma. And I will go into a bit more detail about these things a bit later. So there are far more minor criteria than major criteria. These are bruising unrelated to identified trauma and or on unusual sites. So if people just have bruising on the fronts of the calves or on the arms, that's not particularly unusual. It's more if you've got it on the back or the buttocks or the face. That's what we mean by unusual sites. People may have thin translucent skin with increased venous visibility. There may be a characteristic facial appearance. The facial appearance that doctors think of when they think of vascular EDS is actually only present in less than 5% of people. So the vast majority of people with this diagnosis, clinicians may disregard the diagnosis because they don't think you look like the textbook pictures. So spontaneous pneumothorax is also a significant issue. Acrogeria, which is the prematurely aged appearance. Talipes equinovarus, this is clubfoot. This is much more common in vascular EDS than it is in the general population. It occurs between 8 and 15% of cohorts with beds as opposed to 1% of the general population. And congenital hip dislocation, this is also about 10 times more common in vascular EDS. Tendon and muscle rupture, it's interesting it's on that criteria because we've got 240 patients with vascular EDS, and I don't think, Glenn might correct me if I'm wrong, I don't think any of them have had tendon rupture. And then the other very rare thing, which is in the minor criteria, is keratoconus. Gingival recession and gingival fragility are quite commonly reported to us by patients, but that's difficult to use as a criteria because that's so common in the general population anyway to have some mild periodontal disease. And then early onset varicose veins, so that means under the age of 30 and people who've not had a pregnancy. So those are the minimal criteria suggested for vascular EDS, and as I listed on the previous slide, the major criteria, and those are the facts that make someone think that they should do a genetic test looking to see if someone has got this. It should also be considered in the absence of the major criteria if someone's got a combination of the minor criteria. So this is a bit of data from our cohort of patients. As I said, we've got 240 patients. So first looking, this is going through the major criteria again. So those with arterial dissection. So we have found that 27% of our patients have had an arterial dissection, and this has occurred between the ages of 13 and 65 as the first event. And I've listed these arteries in the order in which they occur. So the most common dissections are the iliac and the aorta and the carotid, and one of the ones that are very rare are vertebral overlay. The next arterial phenotype which you might get is an arterial rupture, and I'm not defining what the differences are between these because I know that Professor Woodens will cover this in his talk. So arterial ruptures occurred in 9% of our patients. Again, this is a list of the frequency in which they occur, so gastrointestinal and renal have been the most common, and leg and cerebral the least common. And then arterial aneurysms, and these have occurred in 15% of our patients, picked up between the ages of 17 and 63. So again, it's a similar pattern, not unexpected across all three types of arterial disease. Iliac and renal, again, most common here. And then we have carotid cavernous sinus fistula at the bottom, and 3% of our patients have had one of those and needed treatment for it. So the next major criteria is the spontaneous sigmoid perforation. So the symptoms of this are pain and ileus, and what an ileus means is that the bowel doesn't move. So the normal way that you go to the toilet is you have peristalsis, which is waves of contraction down the bowel to eliminate this stool. Ileus means the bowel actually just stops contracting. So one of the symptoms that sometimes people have is actually they're stopping up to go to the toilet with this as well. And then the serious complication would be sepsis. So that's when the bacterial contents of the bowel leaks out into the abdomen, goes into the bloodstream and makes you septic. The treatment for this is to have surgery, usually to have a defunctional colostomy. And if someone is known to have vascular EDS, if we were asked about it, we would advise not to have it reversed. And that's because there's a very high incidence of people having a reperforation if they do have it reversed. From our data, and this has been shown in previous cohorts as well, that bowel perforations actually occur at 2 peak ages, and that's illustrated on this graph. It's actually in the mid-teens, in the mid-20s, and it's actually very rare that it happens outside of that age range. It occurs in about 20% of people. And then pregnancy complications. As we said, uterine rupture is a major criteria. We found that pregnancy complications do occur in about 50% of our patients. Uterine rupture is very, very rare. Vessel dissection is also quite rare, but those are obviously the most concerning in terms of medical problems. A high number of people have 3rd and 4th degree perineal tears, and also quite a significant number of people have pre and post delivery hemorrhage. And then there's also a significant risk of premature rupture of membranes and prematurity. If the mother does not have vascular EDS and the child inherits vascular EDS, that itself puts that pregnancy at risk of premature delivery as well. And then this last one of the major criteria is the carotid cavernous fistula. It took a lot of effort actually to find a picture for this. I couldn't find one that was very easy to look at. But this is essentially an artificial communication between part of the carotid arteries and the cavernous sinus. And the outcome of that is that you have very high pressure in what is a venous system draining from the eye. So the consequence of that is that you have pain, prominent eye, which may be pulsating, and it will look very red and inflamed. And the treatment is usually to have the communication between the carotid and the sinus embolized in some way. So I also thought it was important to talk about spontaneous pneumothorax, because although this is one of the main minor criteria, it actually can be a serious problem as well. This again occurs in about 20% of people. So in the picture, on the right-hand side, the white-out area, that is where air has leaked between the lung and the other layer of pleura. So there are 2 layers of pleura, one which lines the lung and one which lines the chest wall. If you have a small leakage of air, it may not cause you any symptoms at all, or it may just cause some shortness of breath and some chest pain. If it is a small one, usually they will be absorbed by themselves and no treatment is necessary. If they are larger and more symptomatic, then someone will have a chest drain put into that cavity to drain the air out. And then the most serious event is if you have a tension pneumothorax. And what that means is that with every breath that someone takes in, more air gets trapped between those layers of the pleura, such that it compresses the lung more and more and more, and may press it across onto the heart and the other lung as well. So that's something where someone needs something put into the chest straight away to drain the air out. So ambulance crew would do that. And these are the symptoms: chest pain and shortness of breath. So just to show you some of the features of the minor criteria. So on your left, we've got at the top hands, obviously, and on the bottom feet. Those are pictures taken of a boy who was aged 6 at the time these pictures were taken. So I think you can see that they look prematurely aged. So that's an example of that progeria. The next picture in on the bottom is one showing contractures. So although we typically think of hypermobility with EDS diagnoses, we do have 4 or 5 patients who have problems with contractures as well. Bottom left, bottom right, sorry, if you're looking at it, is a picture of talipes, and that can occur with varying degrees of severity. And then top right, this is appearance of the thin skin and the visible veins that people have. So the testing that we do for vascular EDS has actually been available as a service test in the UK since 2006. And the process is to do blood sample from which you extract DNA, and then it gets sent to our laboratory. You can just look at the COL3A1 gene, and we still do this in the context of when we need a really urgent result, if someone presents pregnant. Or you can do what's called a FTAA panel, which stands for familial thoracic aortic aneurysm, that has the COL3A1 gene on it. And then more recently, we now do the EDS gene panel, because that includes all 50 genes, which include all the different types of EDS and related conditions, such as Lewis disease, Marfan, osteogenesis imperfecta, and so on. The COL3A1 gene is a very sensitive and specific test. It's more than 99% pickup rate, so we feel confident that we can exclude this diagnosis if someone has a negative gene test. There are 3 possibilities of what you might get when you do a genetic test. One is that you find a pathogenic variant, so that's clear, we know what we're dealing with. Second is that you don't find a change in the gene. Now, for some individuals, you may still think that they look like they've got vascular EDS. And what are the possibilities there? Well, it might be that there's a phenocopy of vascular EDS. Now, what that means is it's not vascular EDS, but someone has all the physical features which look very similar. And I think our experience with that before the periodontal genes were identified would be that we saw a couple of people with periodontal EDS who actually appeared to be a phenocopy almost of vascular EDS in terms of their features. And then there will be a tiny number of people who have a rare mutation mechanism which might not be picked up when testing. And then the third possibility is that you get a change of uncertain significance in the gene. So that just means you've got a sequence change. It's never been described before, and we're unclear whether it's affecting the way the gene works or not. There's sometimes things that you can do to try and interpret that a little bit more. One of them that we use if we get a variant of uncertain significance is to do a skin biopsy to see if we have sort of typical findings on the skin. So a skin biopsy is done under local anaesthetic. It's a 3mm punch biopsy, and then it's examined under the light microscope and the electron microscope. And this is what it actually looks like. So we have top left, this is a normal electron microscopy study showing uniform collagen fibres. They're all similar in size and shape, and they're neatly and densely packed. And on the bottom, we've got a patient who's got vascular EDS. And I hope you can see that the fibres are not uniform in size anymore. They're not neatly packed, they're a bit more randomly packed and widely spaced out. It is not a unique finding to vascular EDS though, so we can't use this as a diagnosis by itself. This is what a typical report looks like if you've just had testing for COL3A1. So it tells you the particular change in the gene that's been found and the evidence for why it's been described as a mutation. So some people at risk of vascular EDS don't wish to have testing. Some people who are proband who you might think have got vascular EDS don't wish to have testing. That's perfectly understandable. What are the benefits of knowing specific gene change? So one is that you can test other family members at risk. For those who are negative, you can reassure them that they don't need any surveillance. And if they are positive, they can have the appropriate surveillance. For those people who are planning to have family, this allows them to have testing in a pregnancy by correlative sampling at 11 weeks, or to have pre-implantation genetic diagnosis. There are different types of gene alterations, and knowing the type may be a way of predicting severity and perhaps response to treatments in the future. So this is some data back from 2014, but it still represents the largest cohort that's published looking at what we call genotype, phenotype correlations. So this is where you compare survival against a particular mutation type. So we've got, I'm not sure how clear that is. So on the left-hand side, the null mutations at the top, on average, have the best survival, and those are the ones where you produce half of the normal protein. And then the most severe are the splice site variants. On the right-hand side, this is comparing the different amino acid substitutions in the missense variants. On average, those with the serine are milder, and those with the valine more severe. Patients often ask us what their variant is because they're interested in knowing this information. The problem is, this is an average of 700 people. If you take one family, say with a null mutation, we know, because of the ages at which people have had problems, that there will be people who've had a vessel dissection in their 20s and others with nothing's happened until their 50s. So you can't really use averages to generalise for any one particular person. So we do give all of our patients who've sort of got proven vascular EDS with a culture or pathogenic variant and a card to put in their wallet for emergencies. And this includes this information on it as well, but we do urge people to seek any help for unusual or persistent symptoms. If the symptoms are very sudden onset, to either go to hospital or call for an ambulance. And these things that we're talking about are sudden onset abdominal pain, suddenly feeling unwell in any way that isn't usual for you, and we'll recognise our own bodies and what seems a bit out of the ordinary. Sudden onset headache, this might be a symptom of carotid cavernous sinus fistula, numbness, tingling or weakness of any muscles. And then we advise people to present the information that they have with them, hopefully with them, to the A&E doctors. When you go to A&E, you might find that you need to advocate for yourself, because a lot of the time the doctors you come across won't have heard of vascular EDS, so the information about avoiding invasive procedures where possible, you might need to mention, and also to avoid surgical interventions where possible. This isn't to say that people cannot have these things, it's just if there's an alternative, that's a better idea. And then with heparin as well, this does need to be used as a prophylactic in some situations, and certainly needs to be used after someone's had thrombosis in their leg or their lung, because we don't want people to say, I can't have heparin, when pulmonary embolus can kill you. So you should have the appropriate treatment where required. So, in summary, vascular EDS is a rare connective tissue condition caused by alterations in COL3A1. It's inherited in an autosomal dominant condition. Described the diagnostic criteria, reviewed the process of the genetic testing, and highlighted some of the symptoms I think you need to be aware of. And as I mentioned before, happy to take any questions in the breaks. Thank you.